some more people will be trickling in. Thank you all for coming. It's a real treat today to introduce a colleague and dear friend who's visiting all the way from Seoul, South Korea, and Dr. Hokyou Lee, who has brought also 3 of his doctoral students. They are in town for the American Heart Association Epidemiology Lifestyle Meetings. They're happening downtown starting tonight for the rest of the week. But since they were here, I thought I'd take the opportunity to have Dr. Lee come out so we could show them around the research center, get them acquainted with Framingham, but also Hokyou is really one of the leading epidemiologists in the world, thinking about some of the global aspects of cardiovascular disease and kidney disease recently. Well, so it's a real treat always to hear his thoughts about the field is going, and very much aligned and relevant to what we're doing, of course, here at Framingham. So Hokyou, 10, 12 years ago, when did we first meet? Yeah, when you were still a student, but his rise has been meteoric since then. I've had the real privilege, because I know his mentor, of working with him for a long time. And he has had a real interest and created a lot of interesting methodology and approaches to some of the very things that we think about a lot here at Framingham. Things like risk scores, things like lifetime risk, things like, what are the things that are influencing the outcomes of cardiovascular, stroke, kidney disease, all these sort of chronic epidemics that we're dealing with, and then have different maybe implications in different settings across the globe. So Hokyou now, as you see, an associate professor at Yonsei University School of Medicine in Seoul, South Korea, but really, as I say, a global leader in cardiovascular epidemiology. So it's a real treat to introduce you, to welcome you to Framingham, and looking forward to your talk. Thank you so much.
Thank you, for the warm invitation, and really I had a really good look around the facility, and as a proof, I have this button. So yeah. So as a brief introduction, I'm a physician scientist and epidemiologist with clinical background in pathology and cardiology. And aside from other national and international side, I've been a proud AHA volunteer for 7 years now. I'm involved as a member of the global CKF Science Committee and planning committee. Also very excited to join as an incoming associate in circulation. So I brought this title, the Global CKM Health Risk Collaboration Across Cohort and Global Studies. But really, you can fill in the blank just about it. So I'm very open to any kind of collaboration with Framingham and So as an epidemiologist, we also, of course, in various other research settings, but today I will mostly talk about our insurance data, which I think has the most versatile opportunity for collaboration, parallel analysis with cohorts. Before jumping into that, I came across a really interesting article. I saw this back in preprint, but that was finally published in the Journal of Epidemiology. The authors noted that there are these excellent open data sets of biobank campaigns, open for disease wonder. There is a explosion of number of papers published every year, and since 2022, the growth surpasses what is expected from the previous trends. So there could be many explanations from the authors. I try to try to comment that this may be related to use of generative AI and open access journals coupled with the possibilities of paper mills. But I think it's so it kind of made me look back and see if we have the same threat to the Korean insurance data. So I tried to count this in PubMed, and the current form of the Korean insurance data really started in 2014 as a sample database, and in 2017 it's a fully customized database to the general public, and we see some growth after that, but I see this data set as a semi-open rather than open because you have to physically be in a closed data server to actually analyze it, and there are some very tedious approval process that I don't always like, but I think it serves as a cap, as a ceiling of infrastructure. So rate limits, let's say, to that limits the exponential growth of publication using these data. So we see about 1,000 papers a year, which I think is not like totally out of control. Actually, this is what not many people know. Before the current form of the insurance data, this data actually started as a prototype in 1990s as what we used to call KPIC, and this data set was actually curated by people in our own departments. See on the top right corner, the person in the center is Dr. Hyun-Sung Kim, my mentor, and the person on the left is his mentor, Dr. Saul. And these folks in the 90s, when claims day, when people thought people didn't notice the use of claims data, like these people were already publishing these articles in the journal, really seminal papers in the field, using this prototype of insurance. And unfortunately, I was able to inherit that legacy, and this was my first in this study, which I started this when I was a fellow, and this was in fact my first happy lifestyle poster. Studied the association of diastolic hypertension with cardiovascular effects in young adults, and actually that meeting was when I had gone the first time, and since he was really a mentor to me throughout my career, and this was really a career changing experience for me. So I was very fortunate to continue this legacy with my mentors of this data set, and I'm really pleased that the two of my best mentees are now in Boston. To the left is Dr. Songjin Cho, and goes to page. Right is Dr. Hokyou Lee, another physician scientist in Smith Center, and I'm very fortunate to see this legacy. So back to the KNS insurance data, there are many opportunities. I would say the most important aspect is that it is a single payer database covering the entire Korean population, which is close to 50 million. And the data is available from 2002 to 2024. So that's roughly 20 years of a dynamic cohort follow-up of just about the entire population, from infant to very elderly people, which leads to a large sample size, which allows stability and granularity in various analyses. And this is based on complete, repeated reimbursement data based on fee-for-service system. And it also has repeated health examination, like values of blood pressure, BMI, cholesterol, and so on, with participation rate close to 80%. And this is linked to mortality data, also with lots of that. So altogether provided by a single payer for the entire population. I think it is a unique setting in terms of placement. There are challenges. It's not the most deeply phenotyped cohort like the Framingham, the leading cohort, but we have a very flexible, a wide range of exposures and outcomes that we can find. So we decided to start some project with hypothesis. We can come up with a very quick we can start that based on this very flexible. Generalizability could be an issue, but I would say that the data are most directly applicable to realities. But the way I see it is that they help generalize similar observations. If we do analysis. Use some form of operated generalization, and validity is always an issue. So as really continuing the legacy of curators of this data, we actually form validation studies every year. So we review thousands of medical records based for these cardiovascular outcomes, and we have a good knowledge of how accurate these are in terms of positive values. We're also very excited that we started validating heart failure events, which is tricky, but we started that and we see some very promising results. So let me start reviewing some of our very recent publications. I think it is very appropriate to start with risk factors. Really the purpose of the cause of the system. And I'm sure that we can all agree that these traditional risk factors, including blood pressure, cholesterol, diabetes, smoking, and more upstream BMI and other lifestyle factors, are the key determinants of cardiovascular disease and probably the most important part of this for intervention as well. Now, interestingly, and also these led to the concepts of ideal cardiovascular disease, including all the other lifestyle factors as well. Now, it is interesting that from time to time, there are clinical observations where CNMI patient, and this patient appears to have no prior documented etiology, so to say, in hypertension, diabetes, and these observations suggest that this portion of so-called SPRFs, SPRF standing for standard modifiable cardiovascular risk factor. So this proportion seems very high and it's even increasing. So it up to 27%. And this phenomenon, I think, it kind of puzzled us because for one thing, risk factors are really continuous and optimal risk factor levels are usually lower than considered for diagnosis of diabetes. And unless there is some mass screening to the population, really the clinical diagnosis may be missed. Globally, the preparedness rate for hypertension is less than 50%, probably lower for diabetes. So what we decided to do was the key question was to see whether cardiovascular disease events actually frequently occur without receiving these non-optimal risk factors. And we define risk factor, we define non-optimal risk factor, not based on the clinical threshold, but the points that we think that are closer to ideal cardiovascular health. So that is blood pressure 120/80, cholesterol 200, pre-diabetes, diabetes, and so we use two data sets in parallel. Did this with Mesa. We actually did this like a year or later. With Thomas here, we probably could have done it with Framingham, but we took people who experienced cardiovascular disease during follow-up and calculated how much of those events were actually preceded by presence of these specific. All we saw was that more than 99%, so it's actually close to 100, 99.7%, more than 99% of cardiovascular disease events were indeed preceded by at least one of these events. This was true for various subtypes of events, and this was consistent across the Korean data in Mesa. Not only one, but actually most of these events were preceded by more than two, multiple of these non-optimal risk factors. So see the whole picture, or this is consistent for various types of events, across cohorts and across age groups. Makes sense. So so these results would challenge the notion that so-called sparkless CDD without parent are common. So we challenge that, and I think it's safe to say in a positive way that that the cardiovascular events would rarely occur in the absence of these traditional disciplines. So this actually had a very media coverage, and it was one of the most shared paper chat in 2025 in terms of the now, unfortunately, ideal CDH or having no risk factor, that's very rare with cardiovascular disease. So if we think of it as a CKM continuum, stage 0 CKM, this is really rare. This is an NACE study. So see that prevalence of stage 0 CKM, the overall population is 1%. And by the time of in midlife, after age 45, the prevalence is 5% or less to older ages. So we saw very similar numbers in Korean data as well. When we find the CDH metrics based on simple 7 definitions, excluding without diet information. So all 6 EO CDH factors, those who had all 6 of them are really rare, only 1.4%, even among people age 20 to 30. So we know that CDH good is associated with very low CVD mortality risk, but EOCDH is often lost already during young adulthood, and the question would be: is it too late if once the CDH is lost, and is it better to promote CDH earlier in life? And this was another study that I did on, and on the left panel, this compared baseline CDH score, again defined with 7, and then a follow-up CDH score after 4 years. That's a big baseline, and then events after that. So those in the top rows would have low CBH score baselines for CBH already during adulthood. But if we see an improvement after follow-up, then that was associated with lower risk of breast cancer. We repeated that for kidney events and the positive cardiovascular kidney events as well. And in the context of the CKM continuum. So like the kidney events and the composite cardiovascular kidney events were actually very studied in observational settings. This was a popular approach for randomized trials, but it was less studied for observational studies. But we tried that, and now we see more and more observational studies using methods. So the next is whether earlier achievement of cardiovascular health and maintaining that is beneficial. And this was really a parallel study with Cardia and also with the Korean insurance data. This was not in a single paper. This was more like a back-to-back approach. In Cardia, in both studies we took, their measured the cumulative exposure to CPH using the life essential aids metrics, and then we captured the outcome after that exposure time period. And in Cardia, the outcome was CV events and mortality. In the Korean data, the outcome was CV events and kidney events. And we pretty much see similar results that a higher achievement of cumulative CVH is associated with a lower risk of the respective infants. And to contextualize that, for example, per 100 points years of CVH, meaning that you would have to maintain a 10-point higher cardiovascular health score over the period of 10 years, that would be associated with roughly 35% lower risk for cardiovascular kidney events. And it was useful to see actually the relative risk, the size of relative risk is very similar for cardiovascular events and kidney events. And the absolute event rate was also very similar to the endpoints, which means that the composite of these endpoints would work well with this particular population. I think it's useful for young adults because in the CKM continuum, really, I think CKD, like very old individuals, is it's less. We can think of it like less as a premature event but for young adults, it's definitely a premature event that we should definitely try to prevent. I want to talk a little more about risk prediction, and I think this is also very appropriate in this session because obviously Framingham was the first risk score for this purpose, and the Korean insurance data is really ideal for risk prediction studies as well because we have planning follow-up based on the design. But also, the predictors are based on routine health examinations. We have the necessary variables, and usually risk scores are parsimonious that you don't need as much phenotype for developing risk scores. The outcomes are based on claims data, but these are we take very seriously about validating these outcomes. So this is a useful setting for risk studies as well. So one thing we did was we were involved in a global consortium study of score to Asia-Pacific projects. This was a recalibration study of the original and score 2, and I was very fortunate to be involved in this as one of the lead authors representing 60 co-authors of this project. and this is the original SCORE2 region, and this is the SCORE2 Asia Pacific region. So I would say this SCORE2 model is not really developed for my country's only. So we have our data to really develop our own business. But this is for regions that lack original data to build their businesses. And this was divided into low risk, moderate, high, very high risk region, and calibrated. All the discrimination and calibration is reported in the study, but I just want to point out that among the derivation sample of 4.8 million and validation sample of 5 million, the Korean data was provided about 5 million. So this was more than half the entire validation set, derivation set. So this data was very useful as in participation of a global sourcing study. I guess this is more something that we can relate more. This was a approach to validate preventive equations outside the United States. We tried to use Korean data, Japanese data, and some other data that we can get hands on, but we ended up publishing for the Korean data first, and what we saw was expectedly a similar discrimination as the entrance of C statistics compared to the original events report. But somewhat surprisingly, the calibration was not too much off. So for female, we saw ACP heart failure calibration pretty close to the diagonal, meaning very good agreement between predicted and observed risk. On the right for male, ACP was right at the diagonal line. Heart failure was slightly off to the right, meaning over prediction, but heart failure is the definition itself is always true. So the interpretation of this it's not good. But I would say that the degree of agreement between predicted and observed risk was actually beyond initial expectation. So one way to see it is that we usually just thought that the Western cohort based risk scores, the Framingham, the Cohort equation, would just overestimate risk in the East Asian population. But that could change over time because risk levels evolve over time. So this is actually similar to what we saw with the SCORE2 Asia Pacific calibration, where the performance was, where the calibration is actually similar between low risk European region and low risk Asian region. So with modern data, the derivation and large sample size, I think the fewer risk equations in general is better than what we expected historically. There is still some more challenges, especially regarding prediction in young adults. This is a editorial that I recently wrote. I think I thought it'll come out today or maybe next week. I may be mistaken, but see this example. This is a 35-year-old female with no medical history, but stage 1 hypertension, obesity, high cholesterol, and the 10-year risk is 1% calculated, despite having multiple risk factors at non-optimal level. If 10 years is after 10 years after age 35, it's just age 45. 45 is still too young to develop cardiovascular disease, even with multiple illness factors. So, but in this case, when we calculate 30-year risk, it's 8.5%, which is at the top, the 90th percentile in terms of relative denial. So I guess we need more contextualization based on longer term risk, life risk for people, for younger people with apparently low short term or linear risk in multiple risk factors. I think the recent cholesterol guideline just came out. It has more context to this, but it definitely needs more discussion on the implementation of that. So as I said, I'm pretty much open to collaborations with CKM or other topics that may be of interest to you and I'm really excited that actually my sabbatical is sometime this year. It's fall 1.7, and as much as I would miss beach and surfing in the West Coast. I actually went to college in the West Coast, but shoveling snow from time to time is maybe not the end of the world. I'm really excited for sabbatical. And this is my team. It's always a team effort for good science. I see an incredible team here as well. So I'm really excited for our future collaborations. Thank you very much.
That was a really whirlwind tour of what's been an extraordinary decade of work from you and your team. And I think you see the breadth of the kinds of things that they're interested in. Let me see if we have any questions, either from our online friends or from in the room.
So the data from
Would
our
you please
side.
introduce yourself?
Oh, I'm Morgan Donahue. I'm in charge of recruitment here in Framingham. Your data from Korea is health insurance, but that's everybody enrolls. So it's very complete set across the board, every age. There's there's no outliers or anything, no options.
Right. Unless there are differences in in what variables or information is available in certain populations. But in terms of selection, in terms of enrollment, it's pretty much.
Because I was even thinking about if it's universal, because even here I have had different primary care doctors. Some may focus on that waiting, some may not, or whatever. So even though these are clear cut tenants for cardiovascular disease, it's still very within healthcare. But it would be the same, say universal, everybody goes and everybody gets treated the same way. It's the same principles.
That's a great question. It is like in theoretical in principle, different health systems would have some differences in clinical practice patterns. We expect that, but the health system itself is a universal or more of a socialized medical coverage, and that really dictates high degree of standardization in treatment and care. So I expect more homogeneous practice patterns than what we, for example, we see in the US. But you're definitely correct. In different health systems, different hospitals might have their own practice patterns.
Maybe I'll ask a question. I think what your work really emphasizes is the universal nature of those modifiable risk factors that Framingham has contributed so much to initially discovering, and that context matters, but the relative contribution of each of these risk factors is pretty darn similar everywhere we look in the globe. What seems to be different is that sort of base risk, right? As you pointed out, there are lower risk populations, there are higher risk populations. Perhaps that's related to genetics, perhaps that's related to environment. But once you sort of set the basal rate, the relationship of these risk factors is quite similar regardless of where you are. So if we take that as something that we think is true, using older US equations, like the full Cohort equation for Framingham, as you said, that tended to overestimate risk in Korea. Using more contemporary populations from the US, like events, and those more contemporary risk equations, the calibration, as you showed, is pretty good. So are Americans getting better? Koreans getting worse? So where are we meeting?
That's a great question and a really interesting discussion that we can think of. Well, I wouldn't want to think that Koreans' health is getting worse, because our age-assisted mortality, age-assisted cardiovascular mortality is clearly decreasing. Well, I think one of the portions, well, in the U.S. health is probably better than like Framingham, which was really
The original,
yeah,
sure.
yeah, it's really many years ago. One thing I would like to add to that is the difference there. I think there are different layers of basal risk differences. Like I said, there would be genetics, other social differences. There could be different levels of risk factors in the baseline. So, as you said, the association, the relative risk itself seems to be very similar no matter where in the world you are. But the prevalence of these risk factors are very different. So I guess so when we compare the contemporary U.S. population, Korean population, I think the average risk is still much lower in the Korean population, but much of that could be explained actually by the distribution of risk factors itself, so that the multivariable model controls for that, and the resulting calibration actually. Great answer.
Mr. Chairman from the HLBI. So my question is, it's a Korean population, but is there much diversity within that? So is there kind of sub-diversity within the Korean population? And then what are the effects of people migrating to Korea? Is there a change in rate of risk?
That's a great question. Actually, like years before, so when we design a retrospective cohort, the baseline we use is probably already like 10 or 20 years ago. Back then, immigration was not like a big issue. So there were less immigrants, and there were very few immigrants. So that the movement of the population was very limited. Perhaps 10, 20 years ago. I think that portion is probably increasing. So I think that aspect should be taken into account probably in future studies. And in terms of diversity, I think same applies because of the immigration, the diversity might increase. But the baseline that we use now is considered pretty homogeneous. But that's I think that's both good thing and bad thing. Bad thing is that we have like less diversity and generalizability. That the good thing would be we focus on the findings of the main associations and less risk found due to the diversity.
What's the socioeconomic diversity?
When we look at the associations and the outcomes, there are gradients based on income level, for example. That gradient is, I think, closing. So it used to be larger. It's smaller now, but it still exists. And I think the absolute level of differences between these income levels, I think it's smaller than what we see in the U.S. probably, but it definitely exists, and I think that should be.
Questions? And then,
This is Dari. May I ask a question?
Please.
Hi, thank you for your talk, Dr. Lee. My name is Dari Ko. I am Korean. I'm an epidemiologist. I do a Medicare database research at University of Life. I have two questions for you. So you mentioned that you use validated claims. How do you validate the claims in your research program? And the second question I have is that in Korea, I'm always amazed at the differences, at the regional differences in healthcare access and healthcare outcomes. For example, I was born and raised in a tiny island in Jeju-do, but later I received my schooling in Seoul, and the difference in the healthcare access is tremendous, depending on where you live and where you grow up. Is that something that the Korean government is interested in looking at, or the researchers are interested in looking at, and trying to sort of improve the differences in the regional, reducing the regional differences in healthcare access and outcomes?
Thank you for your question. Can I just speak right here?
Yes.
Okay, thank you for your questions.
Sorry, can you hear him okay?
And so I'm gonna turn on my camera so
Yeah.
people, so she knows who's talking now.
Okay. Can you hear me?
Can you hear us okay?
Can, yep.
Right. Let me answer your second question first. So yes, we are, and the government is very much interested in the regional differences of outcomes or disparities for cardiovascular disease. And it's interesting that you mentioned, Jeju-do. Conventionally, like a rural island. Well, for the record, I mean, Jeju-do is like an island in the south part of the Korean Peninsula. When you think of it, you might expect that like cardiovascular mortality or risk would be higher than an island. And what it turns out is that it's actually the opposite way, because the access to the tertiary healthcare system is much more simple in this island. So for example, a rural area like near Seoul has a more complicated access to the tertiary center than say like in Jeju Island. So it's not so what I'm trying to say is that the access to care and the outcome is very complicated, and it's sometimes the results is opposite to what one would rationally expect. But I agree that it is a very important question, and we actually I didn't share this aspect of my research today, but my team is involved in creating the national cardiovascular disease statistics, and we try to answer the regional differences of cardiovascular events and risk as well. And answering your first question, validating claims data is extremely difficult, and it's a lot of labor. What we do is we sample or we take some of the cases that we define as cardiovascular events in our claims data, and we review the medical records for that specific hospitalization, and we come up with a systematic way of adjudicating these events. So the professionals adjudicate these events, looking at the medical records as true events or not. We compare that with what we define as events in the claims data. We calculate the positive predictive value. Now, the reason that we don't calculate negative predictive value is that negative predictive value is we expect it to be close to 1 because the event rate is really rare. Does that answer?
Yeah, I guess. Yeah. So the question that I guess I was trying to get at is, so in America, so I work with claims all the time, Medicare data, and it's just so hard to validate them, because even if I validate it, let's say within Beth Israel Deaconess Medical Center, that validation may not be translatable to, let's say, a Boston Medical Center. When you validate the claims in your research, is that using, let's say, EHR from Yonsei, or is it also EHR from other health institutes?
Thank you for that question. I'm really glad that you asked that because you know the first year that we did this, we actually looked at we actually sampled hospitals from the entire nation, and we looked at all these records, like thousands of records, like all over the country, and we pulled that and we calculated weights based on the probability of having events in that specific hospital. And we calculated a full estimate of positive predictive value. Once we have that, now what we do is we just pick several hospitals, including this first hospital that I work in, and just monitor that for changes, for any rapid changes in the accuracy. But first year, as you said, we looked at like many institutions all over the country.
That's tremendous. That's, wow. Jealous, okay.
A lot of work.
Yeah, a lot of work and a lot of, yeah, strong work. Thank you. It's really impressive, your research program.
Thank you.
Thanks, sorry. Any final questions? Well, again, I want to thank our guests so much for coming and being with us today, spending the day. You'll have some busy days at the upcoming FE Lifestyle meetings next few days, but also want to thank all of you for attending today.